Good afternoon. Um, my name is Luis Gomez, and I am on the education faculty at UCLA, and I'd like to welcome you to this panel discussion on becoming the best at getting better, a learning systems perspective. And our panel, in addition to me, is Dr. Rob Cherry there, who is the Deputy Director for Community Health. Nope, that's you. I'm sorry. Who is the Chief Medical Officer and Quality Officer at UCLA Health, and Dr. Mark Ghaly, who is the Deputy Director for Community Health for Los Angeles County Health Services. We're going to have a conversation that will start with Rob Cherry saying a little bit about what he does and how he brings a learning perspective to it, followed by Mark doing the same thing. And I'll say just a little bit more about who I am and have that as a way to springboard into a little conversation between the three of us. And that conversation will then be joined by questions that we hope you will have of these guys. So let's start with Rob.
Well, thank you, Louis. I appreciate the opening remarks. And just as background, I'm a trauma and critical care surgeon by background and the Chief Medical and Quality Officer for UCLA Health System. What that exactly means is it's similar to a more contemporary term of Chief Clinical Officer. What that essentially means is having oversight and accountability for the clinical outcomes that our patient population receives and that we're responsible for throughout our community. There's a lot of things that's involved with that, and I think a lot of you are actually involved in research and efforts to partner with health systems in order to achieve optimal care. It's certainly a very dynamic healthcare environment right now. There are many challenges out there. I'm sure if you've been looking at your phones and reading the news, you're still getting continuous updates on what is or is not happening with regards to legislation coming out of Washington, D.C. Nevertheless, I can tell you from my personal experience that CEOs, chief medical officers, chief nursing officers, and other clinical leaders within the health system are all articulating really the same thing, that this is still an environment in which there's a value proposition for our patients. In other words, there is a demand and there is a cultural shift that we do have to provide optimal care as best as we can, while still making sure that the patients have an experience that meets their expectations, and at the same time that we're good stewards over the resources that we do have by reducing costs and being very, very efficient. That is a consistent message, I think, of any leader that you find within a healthcare delivery system, and that's pretty much true. How you get there, though, is a little bit different between one system and the other, because each community is a little bit different. I will say, though, that since you are going to be talking about professional development issues over the course of your breakout sessions this afternoon, what I found, talking with others in this space, that there's probably 6 different domains to really, focus on. The first and foremost is really keeping an eye on innovation, and how do we do that, and how do we learn to be innovative in the healthcare environment. And I just don't mean, just general innovation, but I'm also talking about disruption in terms of how we deliver care, and not only to be disruptive in terms of changing the healthcare delivery model, but to also recognize very early on when disruptions are actually being introduced into the environment, so that systems can actually recognize and adapt to it without undue disruption to, or at least major disruption to how we currently conduct business. The other area that I think individuals are also focusing on has to do with essentially operational efficiencies. We are not very efficient, both operationally and clinically, how we deliver care, and we need to learn how to do that better. We're still very much a high-cost structure, and we have to figure out that value proposition in a way that makes sense for consumers, because they're still experiencing high out-of-pocket costs, higher deductibles, and there are real concerns that the financial situation with regards to healthcare is not sustainable for people as individuals, and also health systems at large. The other thing that I hear, too, in the healthcare environment is this rise of consumerism, and that's really kind of been catching on lately, that consumers are taking more and more control and exercising more and more demands in terms of their expectations for healthcare, particularly around issues regarding access, whether it's access to emergency departments, access to mental health, access to clinic and office visits, and also transparency to cost, too, because people are having a hard time figuring out when they see a doctor or other types of clinical provider what it's going to cost them. And the other thing is we've made it increasingly complex to navigate through the healthcare environment. And so that consumers are also very concerned about how to really consume their healthcare in a way that's efficient, manageable, and kind of gets the job done and meets their expectations. The other thing in general is just leadership development, not just retention and recruiting and retaining people, but also developing leaders in a way that allows for cultural change within health systems. I think it's easy to teach them change management tools and Lean and Six Sigma and all those types of things, but teaching leaders how to embed, a safety culture, high reliability, right down to the rank and file in the organization is exceedingly difficult, and it's a skill set that has to be, learned and managed overall. The other challenge, too, I think, in terms of learning systems is social determinants of care and healthcare disparities. We do have a great deal of issues with that. We do need to learn how to problem solve through the social determinants of care. I really do believe that in the U.S. we do have the best healthcare in the world. The problem is that it's not deployed well. It's very uneven, and people's access to it is very different. And a lot of that is driven by the disparities that we do see and some of the social determinants of care. And then finally, I would also say that, as we transition from a fee-for-service environment to one that's more value-based, I still think that we're still going to be, by and large, a reactive, disease-oriented healthcare delivery system. Until we really make that true transition to wellness, where consumers also have personal responsibility and accountability for their care, we're still going to be, challenged by preventative care. We have an increasingly older population with a lot more comorbidities, and how do we reverse course on this so that people are healthier, living longer, and having a good quality of life, and taking personal accountability for their care is also part of the learning curve as well. So those are my early comments.
Great. Good afternoon, everyone. Thank you for having me. I don't frequently get invited to these talks, so it's fun to be here. And as I was thinking about what I could offer, and the selfish notion is we have a lot going on at LA County DHS, and we need help, and we need your help. So I hope at the end of this, there's some idea there that says, hey, I might be able to help you, and I could put you in contact with, either myself or somebody on my team to think about that. But I'm going to start by describing a little bit about what my job is, and then I'm going to talk to you about at least 3 questions that I hope can springboard into other broader questions to engage with all of you on. So my official title is Deputy Director over Community Health and Integrated Programs, which isn't always easy to explain in a county where most of the community health functions have largely lived in public health, and DHS is, frankly, a bunch of hospitals and clinics with a few other things on the side. But I think over the last 6 years, that's evolved quite a bit, and I think the best way for me to tell that story is by describing some of the areas I have a privilege of working on. So first and foremost, I'm a primary care pediatrician. I work at MLK Outpatient Center in what we call the medical hub there. So I see patients, kids in the foster care system, not the question of whether, they've been abused or not on the forensic side, but on the sort of primary care continuity side. And as I like to tell everyone, my most valuable administrative time is my time in clinic, right? That's where you get to learn what does and doesn't work, how annoying the fact that the fax machine isn't working today, how that disrupts care. And I think those are the core realities, as Robert was describing, when we think about how our health systems don't deliver the way they should. I mean, it's small things like that that inform leaders like all of you and hopefully myself on the day-to-day way we approach our work. So I always lead with that as probably the most important part of my job when I think about what I do. In terms of programs that I've either accumulated or really gone after to be a part of, I think there's some themes. I like to describe most of what I end up working on are for the patients who fall through our safety net. So it's those with not just classic health conditions, but really, as someone said, the trimorbid, right? Those with serious mental illness, those with serious substance use disorders, as well as medical issues. So I take care of, as I said, in clinic, the work with kids in the foster care system. Also related to pediatrics is our juvie health system. So all of the care in the juvenile halls and camps. We've really changed 10 years ago. If we were having this talk, I'd tell you we have about 10,000 kids in custody on any given day. LA County has done an amazing job of getting kids out of custody. We're now down to 1,600. But I think the big question is, well, what's going on with the 8,400? I mean, nothing in our society says those kids are well and better. I think we're just not incarcerating them, which is great, but what are we doing for them? So that's a challenge that I think in this area is really interesting and worth thinking about. And then largely, the other work I do falls on the side of families and adults. So as a collection, I help oversee our Housing for Health division at DHS. So 6 years ago, we came down with the bold notion that not so bold anymore, which we're grateful about, that sick homeless people don't get better unless you house them first. And the money we were spending in the hospitals and the EDs could hopefully be pivoted. Not a very complicated argument, but not all systems have figured out how to do that. And we're starting. We started small. We're up to about 3,000 people now, on our way to 10,000. And so that's exciting. I also work on two projects that are closely linked. One is we recently, DHS took over from the sheriff and from the Department of Mental Health all the running of jail health. So as some of you know, LA County is home to the world's biggest jail. We have on average 16,500 people in custody. When I describe it to my kids, it's as though you took everybody who lives in our city and put them behind bars, and their jaws drop. So it's huge. And in the past, that system of care had been fragmented, and now we're trying to bring it all together. And just this week, we transitioned the last 1,600 staff to DHS. So now under DHS, we have something called correctional health, and that's really focused on the care within the walls of the jail. I see Dennis in the room who's helping us work on how do we work beyond the walls of the jail on the reentry efforts, and that sort of leads into the other area. A couple of years ago, our board of supervisors created something called the Office of Diversion and Reentry, which is, the notion is that a lot of people are in jail today because of unmet needs on the medical or clinical side, right? Serious psychiatric disease, serious substance use disorder manifests in often nonviolent, but sometimes violent crime. And I like now saying that the courtrooms are our new clinics, right? We have judges, DAs and PDs making clinical assessments, right? And so the notion of the Office of Diversion and Reentry is to say, no, let's not have incarceration be the answer for those folks. Let's see if we can get them into the health system and try in a more dignified way to take care of their needs. So I look at the work between the jail health and Office of Diversion and Reentry, and frankly, Housing for Health, as one big unit that is connected. The other areas of work that I've done, we started, it was a big part of my life before I came to LA, and so I was bent on getting it to happen here, really building a community health worker program within our safety net. So we started something called the Care Connections program a few years ago, which is embedding community health workers in our primary care system to really help with the patients that I like to sort of describe as our noisy outliers, right? It's a small group of powerful patients that single-handedly disrupt your nice, clean health system, right? And hopefully it's an effort to start to take care of some of their needs in a not so traditional way so that the health system works better, people like working there, and patients get the care that they need. And then I have the responsibility, which is all tied together with this, to really watch out how our facilities work with those in our psych emergency rooms, in our psych inpatient units, to figure out how we have that system work well by building up a set of community resources, whether they're housing options or other sort of more formal clinical options, so that people can exit institutions, right? So that's a theme of what I do. How do we get people to an appropriate but less restrictive area of care? So there are other things. One other thing that you heard today a little bit about was whole person care. Some of you had a chance to hear Dr. Clemens Hong, who I work with, talk about whole person care, which for those of you who missed what that is, I'll just do the 30-second summary. It's under the 1115 Medicaid waiver. It's a demonstration project pilot program for 5 years that in LA alone, if we get our second round application approved, will create about a $325 million a year total program targeting 5 vulnerable populations and what will be 14 programs, everything from creating the largest jail reentry project in the nation to expanding our housing for health efforts and building the support services to some very specific programs around the most vulnerable mentally ill and substance use clients in our county. So that, in my view, is in a large program that sort of reaches across all of the areas that I work across. So in some ways, it's very satisfying to have had a chance to work with whole person care, because it is hopefully going to become the connector between a lot of other things that sometimes feel loosely connected. So after all of that, I think my summary of what I get to do, I like to call myself, because everyone likes to have chief in their title, so I'm going to do the same. I like considering myself as one of the county's chief dot connectors, right? Because all I do is figure out how to disrupt the way things are working by forcing or suggesting that 2 dots that should be connected should connect, right? And so that creates a disruption in real terms, right? People get upset. People are like, why do we have to change the way we work? But the hope is that those connections and that alignment gives us some efficiencies, some opportunities to create a more functioning health system, and hopefully at the end of the day, it's better for patients and clients. So I'm going to stop with that before I launch into my questions. You might egg me on to bring those forward.
I will egg you on to bring some things related to those forward. So just a small bit about me and why somebody who sits in a Department of Education at UCLA is sitting up here with these guys. By training, I'm a cognitive scientist, and I sort of an academic cognitive scientist, and I got an opportunity when I got out of graduate school a long time ago to go work at the then Bell Laboratories, where I stopped being by training a cognitive scientist and started being by training a problem solver, because that place was probably at the time the world's foremost place on working on technical problems that created things for people. And then I became a professor again, and I realized how strange academic life is with respect to the problems that people experience every day. And along the way, I got to work at a place called the Carnegie Foundation for the Advancement of Teaching, where I'm now a fellow. And the person who's currently the president of that thing, Tony Bright, and I have been colleagues for a lot of years. And at his presidency, he wanted to turn the foundation into a thing that created resources to help education professionals improve people's lives. And education in lots of structural ways looks a lot like public health. And we were about 10 years ago scurrying about trying to figure out, well, exactly how do you do that? And in our travels, we happened to meet Don Berwick, who runs the IHI, the Institute for Healthcare Improvement. And he talked about the way he does his work. And we said that education should do its work that way. And I will be very briefly, in mainstream education, people talk about doing things for policy and practice, for example. And policy and practice kind of rolls off our tongues as though those two things are equal. And what we have, if we have anything in the main, is we have a science that gets to prove things so policymakers can go spend money. But we don't have a science that really focuses on the improvement of practice. And what I think I learned in going to school on the work of the Institute for Healthcare Improvement was to focus critically on practice, and the idea of having an academic and practical infrastructure aimed at improving practice was a worthwhile thing to do and a very, very difficult thing to do. So that's how I get here to do this work and get here to ask you folks questions. And I guess what I heard in your comments are several themes, and maybe I'll start with one. One of the things that I find troubling, and I just gave a little paper about this a few days ago, is that we create lots of innovations in our business, and I assume you create lots of innovations in your business. And those innovations often work really well for some segments of the population, and those innovations often don't work really well in practice for others. So you signal a theme of equity in social determinants of health in your talk. You had equity undercurrents in what you said. How do you, in your work, think about creating learning systems that sort of mitigate these problems of equity and social determinants of health and well-being?
Well, I'll take a shot at that, but I don't have the secret sauce for it, unfortunately. And it's a really great question, and it also dovetails on Mark's comments as well. So let's take, for example, problem solving and developing innovation around emergency department wait times, okay? And maybe, a few of you may have gone to an emergency department and had to wait, excessively long periods of time to see the physician, get the diagnostic studies, get a treatment plan, and maybe at the end of the day, just get discharged home. Well, if you come to UCLA at Ronald Reagan Medical Center on any given day, it's very likely that sitting in that emergency department are 8, 10, 12, maybe even 15 patients in the emergency department that are actually psychiatric holds. You've mentioned, the issue with, mental illness. From chief medical officers all around the country, including in California, the mental health problem is significant. We don't have enough resources in the community. I know there are efforts to do that, but we don't have the outpatient and inpatient resources to be able to keep them from coming to an emergency department and be able to effectively treat them in an urgent care type of setting. And it's not the only reason for prolonged emergency department wait times, but it is a top reason for emergency department wait times, at least at our organization and many other organizations as well, is the number of psychiatric patients that are in our emergency department, some of which have physical illness as well. So then we're dealing with a dual diagnosis. So part of problem solving through innovative ideas is also, I think, immersing yourselves in the healthcare environment to really understand, what are some of the root causes and why is it that some innovations work in some places but not others. So like at Santa Monica, for example, we may only have maybe 2 patients on any given day that might be on psychiatric hold, much different than in Reagan. So if you would apply the same innovation to one facility versus the other, you might get a different effect because the patient populations are a bit different. Another issue is that you have to get them out of the emergency department up into the floor. And so what are the issues that are causing blockages in throughput, and how come you can't get the patients through faster? And again, just to dovetail, on Mark's passion for public health, we have in the state of California and all around the country an opioid crisis, right? So the number of people since the crisis that began that have died because of opioid addiction, I think, is around 200,000 people. It's quite significant. And what you'll hear, you will hear stories like this from other chief medical officers. Had a patient who is addicted to opioids. They came in because their heart valve was infected because of intravenous injections. They treated them with IV antibiotics, but they have to discharge them home. Now, if the person wasn't addicted but had, let's say, a routine valve infection in their heart, you can send them home with a longer-term catheter, and it could be managed with home health, and you can give them the IV antibiotics at home. Now, for someone that's addicted to opioids, you can't really send them home with an intravenous catheter and expect only antibiotics to go through that catheter. So they end up sitting in the hospital until their treatment is actually completed, which could take 4 to 6 weeks, and then they're discharged home. So some of the patients sitting in the emergency department that we can't get up into the floors are also challenged with some of the healthcare disparities and some of the social determinants of care that are kind of blocking some of the throughput issues. Now, here's the interesting thing. That patient, once they're treated and they're discharged, and I've heard this before too, they then come back, right? Now their heart valve is infected a second time, maybe even a third time, and now they actually need a valve replacement. And so now they're in the hospital getting surgery to get their valve replaced because of their opioid addiction. These are some of the challenges that we're facing. So we have to develop innovative strategies, I think, within our communities, both in terms of mental health, in terms of opioid addiction. Physicians need to, optimize, our prescribing habits so we can keep people out of addiction as well, and so that they're not really in this situation to begin with. And I think that the more that you kind of immerse yourselves to understand some of the complexities that we're facing, I think we'll do better. And it requires a village. It requires health services researchers partnering with public health. And yes, we do need an innovative curriculum that's disruptive, so that we can teach people how the skills that it takes to develop new paradigms for delivering health in a much more efficient and effective way.
I'll try to be brief. I think when sort of thinking out loud a little bit with you all, I think sometimes when we think about equity, we think about really what I want to think about is equity in outcomes and equity in a chance to achieve health or achieve something, and not necessarily equity in approach, right? And when I think about sort of, let's go back to this sort of noisy outlier comment, right? Those who interact with the health system in a unique way, not always the way we would love it or like it, and it disrupts things. I think that those populations often need something different. Right, and I certainly want my career to be in the business of figuring out what works for that group, both because I want them to have equity in outcome, but also because I think it gives the rest of the system a chance to function the way we all would like it to. So I'll stop with that, but I think there is that difference in what we're trying to achieve from that sort of equity perspective.
I think, yeah, I appreciate both your comments, this idea that equity in outcomes means that you may do radically different things for different kinds of people, and I think both of you are signaling that in your comments. So if you're the chief dot connector, and I wonder, so one of the things that I suspect that a chief dot connector, whether you're so named or you happen to be the chief quality officer.
No, I agree with that title.
I wonder if part of that job is attacking silos of practice, and when you attack silos of practice, either in UCLA Health or in Los Angeles more broadly, I'm wondering, it's been my experience at least that attacking silos of practice often involves getting people to share and engendering trust among them. And how in your role as in both your roles as dot connectors do you attack the problem of sharing data on the one hand for common aims and engendering the trust on the other to get that done?
Yeah, so I totally agree with your comments. I've had people ask me, so what do you do? What's your day like? And I do tell them I spend probably about 90% of my day actually connecting people and ideas. UCLA Health is a fairly large organization. It's about $2.5 billion organization, and it has 180 clinics dispersed in and around Los Angeles. We have about 2,500 docs that practice there full or part time. And because it's a creative and innovative institution, it does have a relatively decentralized model. So it's very easy for silos to develop. But I don't mean silos in a negative way. I mean in the sense that people see an opportunity for positive change and they dive into it and try to work on that change in their local environment, often not knowing that there's somebody else in a different part of the organization that's working on a similar problem. And the issues then become a matter of scalability, because there's a lot of great ideas there. But unless you sort of connect the intellectual resources and the supplies and equipment and the funding all together and bring these disparate groups together, you won't get the kind of scale and traction that you actually need. So part of my major job, I think, as a connector is also a disruptor of how we do business as usual within people's local environments, so that we're able to bring them together. I think part of disruption too is that it's also very easy for health systems to become isolated from other health systems, from payers, from public health and other community organizations that can bring value to the patient care delivery model. So, one of the things that we're paying much more attention to is who else is out there that can actually help us affect change.
So when I think about it, first, I've learned that you can't really accelerate trust building, right? It just takes time. People, you need to get to know them, you spend time with them, you call them after, before hours, right? Like that's how you develop. And I would love to figure out a way to do that faster. I don't think you can. I mean, I haven't figured it out. I think the other thing, the silos exist because for many of the reasons you mentioned, the money flows that way, the org start flows that way. And I think the other thing, and this sounds, without being cliche-ish, sort of the whole raise everyone's boat concept. I think you struggle if you can't figure out the win-win, right? If there's a win-loss, cutting through a silo is going to be really tough. And I think that's what's sort of exciting about innovation, right? Like the innovation is you got this person doing it this way and this person over here doing it their way, and you want to bring them together. It's on us as innovators to figure out what is that win for both of them. It can be an uneven win. Like, I think I found that people are okay as long as they win a little bit. But I think that's really important. The concept and kind of the broad vision, it's always nice to tie it to how patient outcomes improve or the system improves. But if at the end of the day, people feel like you're taking something off their plate that they want or that they don't win as a group, I think it's really hard to break it down.
I have a good friend who's about to move to Rutgers University in Newark. He's a historian, but he's really a civil rights activist. And he says that the work of change in the civil rights community is developing the ability for slow and tasteful work. So we have like 3 or 4 minutes before 1:30, and I would be remiss if I didn't offer you all the chance to ask questions of these guys. So I could proceed with other questions, but you should have the opportunity to do so. Ah.
Uh, There is an updated org chart. I don't know where it lives. It could be on the internet. I haven't looked at it lately. Um, yeah, no, and let it be clear, he's still the director of health services. Sure, we can, under the org chart, you'll find my name and then a list of all the things that I went over and mentioned. But I'm not sure the last time it was updated. And if it's not there, I can try to help figure out where it is.
By the way, here's one thing that we all share in common in healthcare. Where's the org chart?
From a community perspective, it's hard to know who you go to for what, because there's some major changes and reconfigurations with the integrative piece coming along, and behavioral health, substance abuse, all coming under health services now, and people trying to navigate and figure out what's what. I mean, it's important to have that document somewhere where it's accessible.
Sure, I agree.
So I have an easy question that would require just a short, easy question that would require a short answer from each of you. If we're talking about learning health systems, what is the vision for where we're going with respect to the learning healthcare system? What does a highly functioning learning health system look like to you, and how close or far are we from getting there?
Yeah, a learning system really, a healthcare delivery model is one where it's easy for the patient to get a same-day appointment, where the doctor understands exactly what's in their medical record, and they can translate that information into a joint decision with the patient, where they understand where to go next without having to make multiple phone calls, that we screen them effectively each and every time for colorectal screening and diabetes care and keeping their hypertension under control, and that we're able to meet their needs at home so that holistically, as an integrated family unit, that they're able to support each other and optimize their care. And that's part of the answer. And it also has to be cost effective and affordable and accessible for everybody.
Yeah, so I'll jump in just to react to that briefly, and then let others share their thoughts. One thing that I've learned from Brian is that a lot of us think about a distinction between the high-performing health system, which I think is what you just described, as opposed to a learning health system, which has the ability to use their own data to improve care in a continuous way, the way Toyota learned how to, build cars more effectively. And there are definite links between the high-performing health system and the learning health system, but I think they're kind of different competencies that reinforce each other. So others?
Sure. I think one of the, without a sort of global comment on where we are, I think where we have work to do together is reconciling the messiness of everyday life of some of the clients and populations that not so high performing health system often faces, and sort of the contribution of academia and research in that, right? So I often face folks are like, oh, I'd love to study that, but this is how I would suggest to study it, and knowing already that that model doesn't work. So working together to reconcile that middle ground between the messiness of the work and often the tried and true practice of the way that you investigate and research it. There must be something in the middle, right? To turn to all of the really complex, interesting questions in community health or that live with outside the walls of a health system and say, look, we don't have a model, you don't fit into our box, is sort of unacceptable for a long-term answer. And I think we all have to struggle together to figure out what the right answer is and get there.
And many of the physicians, because they do want a learning environment, but what they are often asking for is they need the analytics. They're often asking for expertise and help to navigate the change. And they are asking for the curriculum and the skills to be able to interpret information, be able to learn from that information, and be able to drive performance improvement within organizations. You hear that consistently throughout, multiple, healthcare delivery systems where physicians are very much engaged in driving change within their environment.
So time's up. We appreciate your comments. Thank you very, very much. And I appreciate your attention and questions. I think we're done.
Thank you so much. And as the person who's introducing the next session, which relates to this question, for those still on the panel, if you want to take 30 seconds or 60 seconds and just answer one other question, if you want to flee, that's all right as well. I know you need to get going, but one question I think that relates to the next session is if we came together again in a year, is there anything, when you think about us as a collective, is there anything else, what would be different? What could be different that we could be satisfied that we did?
This is for me.
Well,
This is for anybody.
Yeah, well, first of all, I'd like to see one of you partnered with us up here because we just can't get it done unless there's community organizations, health services researchers, and other committed individuals who want to see, accelerated change. So it takes, partnership. And so that's what I'd like to see. Mm-hmm.
So I will get through my three things because of this question. Our county passed Measure H a few months ago, right? And $355 million a year for the next 10 years is going to flow into the county to combat homelessness. And our department, and I think many others across the nation, have turned homelessness into a health issue. Right, so it is fundamentally an issue that you and all of us think about and should research. And I guess my thing a year from now, if some of you are helping think about what makes something like H successful and worthy of sustainability, because 10 years from now or 8 years from now, somebody's going to go back to the voters and say, look, we want to keep it going, we want to scale it up, and some, those who ask questions are going to say, well, why and what have we done? And I think we, people in this room and broad groups, have a chance to say something about that, good or bad, right? And so I guess that's where I would love to see people engage and think about it.
This one, Adam.
I don't know a huge amount about what would make a learning healthcare system. Of all the people in this room, I'm probably the neest of neophytes. But I would say that I believe the hardest problem for learning systems to take up, to make progress, is to agree on what the problems are. And so if we were to come back together in a year, I think a big part of the progress would be for a large swath of people saying, if we make progress on these one or two things, life chances will be a whole lot better, and we have theories to help us get it done.
All right. Thank you so much. Thanks for the extra 3 minutes of value we just extracted from all of you. That's great. So we are going to move into now a strategy session, and this is the time where we get to reflect on all that we have talked about today so far and all your pent-up ideas about what we could be doing differently as a collective. And so what we'd like to do is move into the concurrent strategy sessions. I think we have 6 of them. And the way we've structured this is an opportunity. There will be a facilitator there, a moderator, to help set out some questions, but in general, this is an opportunity to have a shared discussion about what could we do next in some different possible areas of strategy or work together. So I just want to mention there are 2 of these groups will be meeting here in Yosemite Hall. Emmeline Chung will be talking about building capacity in smaller systems and low resource settings, and why don't we have that group meet over on that end of the room. And then I'll be talking about professional development in healthcare systems, and why don't I go here. And then there are 4 other groups partnering with healthcare organizations, building capacity outside of healthcare, so public health, mental health, juvenile justice, the systems, innovations in academic training, and building leadership capacity are the other topics. The way we structured these is we want to give people a chance to rotate, so we're going to give this a try, which is to have 2 30-minute rounds. If you want to stay in the group that you started with, you can, but we're going to allow for about a 2 or 3 minute break for people to shift in case you want to add to 2 conversations. And the second group will just try to see what the other group first talked about and then add to that. So we're going to have sort of 2 30-minute sessions, and then we'll come right back here to this room for reporting out and then a close. And our plan is to get everybody on the road early. So this is sort of a lightning session, so we'll have 2 lightning sessions, brainstorming, sharing ideas. And the questions that we're really posing are, what could we be doing differently? What ideas do we have about how we could do things better? What do we need to understand more about the approaches that we could then potentially use here? What would it look like if we could? And what are some concrete next steps that we could take for next year to be different than this year, and so forth? So those are the kinds of questions that we'd like folks to grapple with in these 2 30-minute rounds. So there, again, on the agenda shows the room assignment to each of these topics, and we'll convene back here at about 2:45. So we'll have the moderators do some herding at the end of the second round. That's it, right? Okay, great. Thanks, everyone.